Okay, so just a little background on Dr. Polotti. So Dr. Charles Polotti, he's a fellowship trained urologist who specializes in performing minimally invasive procedures, including laparoscopic surgery and advanced robotic assisted surgery. Dr. Polotti earned his medical degree from Drexel University in Philadelphia, Pennsylvania, and he completed his urology residency and a surgery internship at Rutgers Robert Wood Johnson Medical School in New Brunswick, New Jersey. Dr. Polotti completed his fellowship training in advanced robotics and I'm tongue twisted, laparoscopy at the University of Southern California's Institute of Urology at Keck Medicine of USC. During his training, Dr. Polotti earned the Resident Achievement Award for Outstanding Minimally Invasive Surgery, MIS, a resident from the Society of Laparoscopic and Robotic Surgeons. Throughout his career, Dr. Polotti's urology research has been published in peer-reviewed medical journals, and he has presented his findings at various regional and national conferences. Dr. Polotti is also a member of the American College of Surgeons, the American Urological Association, and the Society of Laparoscopic and Robotic Surgeons.
Thank you very much for that introduction.
You're welcome.
So we'll get started here on behalf of the Capitol Health Cancer Center, Dr. Chen and myself. We're happy to welcome everyone this evening to talk about prostate cancer, and we're excited to be able to present this program to you. So I have no disclosures related to this material and just some objectives for the talk tonight. We're going to be reviewing some background information about prostate cancer. We'll include the risk factors and any prevention, how prostate cancer is screened, and how we diagnose it. We'll go over in detail. This is really the meat of the presentation for the treatment options, including active surveillance. We'll talk about robotic surgery for radical prostatectomy. And then Dr. Chen will take over and go over radiation therapies. We'll travel actually on a virtual tour at the end of our radiation oncology suite. And we're going to be learning more about the CyberKnife technology. And then really an important objective from my perspective, and probably Dr. Chen's as well, is really just to leave no questions unanswered, whether that's in the chat, a Q&A at the end, or setting up a consultation with either of us to discuss anything in the office more privately. So just some facts and figures here. Prostate cancer is the most common non-skin cancer in men, so the #1 solid organ cancer in men. And there's an estimated a little over 268,000 cases that we believe will be diagnosed in 2022. It's actually the second most common cause of cancer-related death in men, and lung cancer still remains the first. So we do estimate about 34,500 deaths will occur related to prostate cancer within 2022. And a majority of these are diagnosed with men between ages 65 and 74, with a median age of 67. But we do know that all comers with prostate cancer, whether it's localized to the prostate, not spread outside of the prostate, if it's in the lymph nodes, even if it is metastatic, meaning outside of the prostate in other areas of the body, has an excellent 5-year relative survival of over 96%. So this is one of two more technical slides, just a little bit of an anatomy lesson. The prostate is a walnut-sized gland. And can you guys see my laser pointer, by the way, Marcia?
Yes.
Okay, perfect. So there's a walnut-sized gland that sits right next to the bladder, which is this sort of balloon-shaped organ up here. This is a side profile of the body, a cartoon version, and it sits between the bladder and the urethra to the outside. It's responsible for contributing fluid and nutrients to the semen. It contains the connections, which are these little tubes back here, for the ejaculatory ducts that carry sperm. And as men age, it naturally enlarges. In all men, this is known as BPH, or benign prostatic hyperplasia. And it does have plenty of nerves and blood vessels that travel adjacent to it, as well as a healthy blood supply to it itself. But these nerves that travel next to it aid in erectile function, which will become important later in our discussion of treatment options for prostate cancer. So what are typical symptoms that men might experience when they have prostate cancer or early signs of prostate cancer? And honestly, the answer is not much, because most men don't experience any symptoms. Truly, the condition is diagnosed mostly based on an elevated PSA value, which is a blood test that we'll talk about shortly. And 9 out of 10, or about 90% of men are diagnosed with localized prostate cancer, that is prostate cancer that is just within the prostate gland itself. Now, these are some possible symptoms, but I really want to point out that they are nonspecific because they can be related to just enlarged prostate, which is benign, or other conditions such as a urinary tract infection, stones in the urinary system, and various other causes. So there might be some weakness of the stream or urine frequency, which is worse at night. You might experience an inability to empty the bladder completely. There could be a stop and go sensation to the urination or difficulty initiating the urination. You might see blood in the urine or semen, but this has a lot of potential other causes and is very nonspecific for prostate cancer. Also, if it's more advanced at presentation, there could be persistent new back pain or bone pain in the hips or pelvis. Again, nonspecific, arthritis, and other things could be leading to this as well. So some risk factors for prostate cancer. Now, the ones I highlighted in bold are the ones that we know absolutely do have a link to prostate cancer. Age. We know that the older men get, the more likely they are to be diagnosed with prostate cancer. The incidence of it does go up. A family history. Now, if you have primary relatives, both male or female, you don't necessarily have to have this BRCA or BRCA mutation. But we do know that men with a family history of prostate cancer, most important in primary relatives, that being your brothers or your father, would raise suspicion for you developing a prostate cancer later on. Now, in female relatives, sisters or your mother who have breast or ovarian cancer, we do know that there is a potential link as well. And sometimes these may be associated with particular mutations. There are some hormonal factors at play. We do know that prostate cancer feeds on testosterone. And on the next couple slides, we'll talk about a potential drug that we believe may prevent prostate cancer, but it's a little bit of a gray area. We do know that race plays a significant factor. African American men are known to be at higher risk for development of prostate cancer, and they in turn warrant an earlier screening at younger ages and a little bit more aggressive of an approach. These ones I put a little bit smaller down here in italics. There are some potential dietary factors which we think may play a role, but really it's not clear cut. There's some evidence possibly that a high fat diet or increases in dairy or calcium within the diet may play a role in development of prostate cancer, but there's been studies saying yes, there's been studies saying no, there's no link. There's possibility of multivitamins, that is folic acid, being supplemented within multivitamins may lead to an increase in prostate cancer, whereas natural folate with fruits and vegetables may lead to a decrease. Prostatitis, which is an inflammation of the prostate, could potentially lead to an increased risk for prostate cancer. However, I take this with a grain of salt because we do know that inflammation of the prostate will raise that blood test number, in turn leading us down the path of more biopsies, in turn probably finding more cancer than we otherwise would have. So can prostate cancer be prevented? And really the short answer is maybe. Now the long answer is, based on what I said in the previous slide, is there a consideration for having a low-fat diet? Should we increase our fruits and vegetables? Well, yeah, that's excellent for heart health and keeping ourselves healthy in other ways. But is it really going to by itself reduce the risk of prostate cancer? We're not sure. But there is consideration to have these things within your diet and moderations within the calcium and the dairy, like I mentioned. Hormonal manipulation. Now, if we cut off the testosterone supply, will men not get prostate cancer? And there was a study done, PCPT is the prostate cancer prevention trial, which happened actually in 2003. And men were given finasteride, which is a drug that prevents the prostate from getting bigger, actually shrinks the prostate, reserved for men with large prostates who have bothersome urine symptoms. And this was actually found that men who received this compared to placebo actually had a reduced risk of developing prostate cancer, or rather being diagnosed with prostate cancer, by about 1/4 to 1/3. But there were no differences in survival, and this was actually teased out at the 10-year data in 2013 and then the 15-year data to say that there were no differences in survival, that is prolonging a man's life or dying related to prostate cancer, whether you got this drug or not. And there was also no increased risk of developing high-grade cancers. The initial data in 2003 did show a link that men who received finasteride did develop a higher risk cancer potentially later on, but this was not found to be significant in the later data. Now, this medication is not without its side effects. It can cause sexual dysfunction. It can lead to low sex drive, possibly erectile dysfunction. And I don't think we're at the point of it being a blanket recommendation that every single man should get this as a preventative measure for prostate cancer. Really, the best advice I can give is that you should just be having healthy discussions with either your primary care physician or consulting with a urologist to better understand your risk factors. So for screening, this always involves shared decision with you and your physician. The AUA is the American Urological Association, and it's recommended that men at average risk who are between ages 40 and 54 should not be routinely screened. However, if there are higher risk factors present, African American race, that family history that I mentioned before of either prostate cancer in primary relatives or prostate cancer at a young age in more distant relatives, or breast or ovarian cancer in the female population. Now, I like to think of it as if you had a family member that was diagnosed at a certain age, you yourself should get screened about 10 years earlier than the age at which that person was when they had their diagnosis. So if your father was 60, you should start your screening at 50, for example. Now, for ages 55 to 69, routine screening is recommended, and we'll talk about what that entails next. And then for men who are over 70 or 70 or above, we should really be considering heavily their life expectancy. And this is not clear cut. There's no calculator we can use to figure out how much longer you're going to live. It's really a decision made based on your other risk factors, other medical conditions, and the longevity within relatives in your family. Now, the screening tools that we have available, we have the PSA, which is prostate-specific antigen, just a simple blood test. And you might see if you get this lab done that values at 4 or below are considered normal. And I put that in quotes because I like to put more stock into the trend of the PSA number rather than a single value, because there are many reasons that can cause an elevation in the PSA. So this is a cartoon picture of a digital rectal exam. This is a physical exam where a physician would insert a lubricated and gloved finger into the rectum, and they're able to, with their fingertip, feel the prostate. And we're looking for the size of the prostate. We're checking for symmetry. Symmetry is good. If there's any firmness, that might indicate an abnormality. If there's any nodules, or what I say is lumps or bumps, or if it's one side is larger than the other, that might indicate or raise some concern. I put MRI of the prostate in here. It's not a discrete screening tool totally yet, but we do use it as an adjunctive test where we would do this to help guide the need for a prostate biopsy if either the PSA or the rectal exam were abnormal. And this really has helped us, especially more recently, to find suspicious or concerning areas that can be scored by a radiologist to give us an idea of a relative concern for prostate cancer, in turn helping us do a biopsy. So using prostate biopsy to diagnose prostate cancer is a tool that's been done for many, many years. It's typically done under either local anesthesia or sedation. And the picture here is an ultrasound probe in the rectum. You're laying down sort of on your left side. The ultrasound probe goes into the rectum, and a thin needle, which is a little bit difficult to see here, but right through here, passes through the ultrasound probe into the prostate and takes several tissue samples. Now, this can be done one of two ways. One is called transrectal. That means going through the rectal wall for the needle to pass through there to get into the prostate. The other is what we've actually switched over to at Capitol Health, is called the transperineal technique, where we still use the ultrasound within the rectum, but the needle actually passes through the skin underneath the scrotum and between the scrotum and the anus to get into the prostate directly. And this actually eliminates almost down to 0% risk of infection, which we're very happy to be able to offer this technique now at Capitol. MRI fusion or targeted biopsies are some buzzwords you might have heard of that has now become very common. And if we find a suspicious area on the MRI test, we can actually use that information with the real-time ultrasound at the time of biopsy to target that specific concerning spot, in addition to doing a template biopsy, which is 6 cores from each side of the prostate, right and left. So the risks of a prostate biopsy are not negligible. I mean, they are real, but they are pretty minimal and very well tolerated. Almost all men will get blood in certain areas, typically the urine and the semen. If the transrectal approach is used, you might get some blood in the stool, but if we are doing the transperineal technique, there should be no needle passage through the rectum, so no blood in the stool. Some discomfort and pain is expected, but typically controlled with just Tylenol. Men can have some difficulty urinating. They may develop fever. This is typically more of a concern if the transrectal approach is used. And in very rare cases, there can be a urinary tract infection or a bacteria that goes into your bloodstream that's known as sepsis, which is a serious infection, which is rare even with the transrectal method, but it is a real risk. And then we're very happy to report that there's essentially a 0% risk now with the transperineal technique. So this is the second technical slide that I warned you about before. Gleason score. Dr. Gleason was an individual who came up with a scoring system for prostate cancer, and this helps us guide our treatment options. So a pathologist will look at a slide from the prostate biopsy, and they'll assign a score based on the two most common patterns, and this is a 3, a 4, or a 5. So based on the two most common patterns, we add two of those numbers up for a total score ranging from 6 to 10. So if they look at a slide and the entire thing looks like a score of 3, they call it a 3 plus 3, which totals a 6. If we see that the 3 is predominating more than the 4, meaning, for example, there was 75% of 3 and 25% of 4 on the slide, that's a total of 7. But we also have a pattern where there could be a 4 plus 3, meaning the 4 was the more common pattern. Essentially, what it boils down to is a higher number equates to a higher grade of cancer, which in our minds as physicians leads to believing an increased aggressiveness, and our treatment options may differ based on the risk groups here. So low risk is considered a Gleason 6, intermediate risk a Gleason 7, and then high risk anything between 8 and 10. There might be some additional testing that we recommend based on a staging in regards to what treatment options you might become eligible for. One of these is a genomic test, which we can actually use the prostate biopsy tissue, and it can help inform treatment decisions and help us actually guide patients in going onto active surveillance or help us figure out hormone therapy in association with radiation, which Dr. Chen will talk about later. And we are able to offer these at Capitol Health as well. They are send-out tests. They typically take a couple weeks to return, and then we could discuss the results. Within high-risk prostate cancers, again, those Gleason 8, 9s, or 10s, or some of the Gleason 7s, those intermediate risk, there may be some tests that we recommend for staging. And the CT scan of an abdomen and pelvis is a sophisticated X-ray, basically, checking for enlarged lymph nodes, or we're looking for evidence of cancer spread outside of the prostate. This is known as metastasis. Or we might recommend a bone scan in certain circumstances. And this is checking to see if prostate cancer is possibly in the bones, as treatment might differ. So for treatment options, there are 4 main categories, and we'll talk about 3 of them. I'm going to talk about active surveillance. I'll talk about surgery, which is a radical prostatectomy, and we can offer the minimally invasive robotic approach here at Capitol. Dr. Chen will go into radiation therapies in detail. And then I do want to mention briefly, but out of the scope of this presentation, there are such things as focal therapies. There's high intensity focused ultrasound or cryotherapy. We do not currently offer these at Capitol Health, but if that's something you're interested in, we could talk to you about it in a consultation and make an appropriate referral to a more academic type center that might offer this treatment. For active surveillance, I do want to be clear that this does not mean no treatment. This is a treatment program, and it's designed actually to preserve the quality of life and reduce side effects of surgery or radiation. And there are many men with low risk prostate cancers, those Gleason 6s, and some men with low volume, meaning a low number of biopsy cores positive of intermediate risk, the Gleason 7, that would be eligible for this. And this is where the genomic test can help support eligibility. Now, for the program that I would typically recommend, and each urologist would probably have small differences in what they would do for this, but generally there's a PSA done on some interval basis. I don't think it's necessary to do more than every 6 months. I typically always recommend a repeat prostate MRI at about 1 year. And not yet has prostate MRI completely replaced the need for what's known as a confirmatory biopsy, but we are headed in that direction. But for now, it's still recommended to undergo a repeat biopsy at 1 to 2 years, called a confirmatory biopsy, which literally confirms the diagnosis to make sure the prostate cancer is not worse than the original biopsy. So for a robotic prostatectomy, robotic surgery in general, at Capitol Health, we have two of the latest generation multi-port robotic systems. These are used across multiple specialists, and really robotic surgery bore out in the early 2000s, late 1990s and early 2000s within urology. So urologists are the most experienced at using this system. So this is the Da Vinci Xi system from Intuitive Surgical. There are two components basically. This first one here that has the robotic arms, these are the 4 arms that actually clip onto the ports, which I'll show in the next slide. And the robot doesn't have a brain. That's what some people might be skeptical about. The surgeon sits at this console here. Once the robot is clipped onto the ports and attached to the patient, the surgeon will sit at this console, is in total control. The robot does not move without the surgeon moving these joysticks here. There are foot pedals to control different variations of the camera movement and other movements. And we're able to look through a 3D viewer, basically, that gives a 3-dimensional and high definition view with impeccable magnification. So this is minimally invasive surgery. Removing the prostate, we do still consider a major procedure, but it's minimally invasive in the sense that it's performed through multiple keyhole incisions, might be about 5 or 6 small incisions about the width of a fingernail on your abdomen. We do have to remove the prostate at the end of the procedure, and that is done through an extension of one of the incisions, not more than about 1.5 inches or 2 inches, really depending on the size of your prostate. But it's just incredible precision. There's a 3-dimensional high definition view. It provides 10 times magnification. And the robot, at least these more later generations, have wristed instruments. They mimic the human wrist for really excellent range of motion inside the body with these very small instruments. And the highlight of this is it provides a shorter recovery. There's less pain. There's less blood loss than open surgery, and really a shorter hospital stay. Typically, folks are just spending 1 overnight in general and then going home the next day. So just briefly about how the surgery is performed. So we won't get into too much detail here. The abdomen is inflated with carbon dioxide. Some space is created within the abdomen for us to be able to work. These are the ports that I was talking about. So these are the access points into the abdomen. Now, we can see the belly button is right here at the laser pointer. So in general, the ports are in a line across the abdomen, basically in line with the belly button here. And then there is one port for an assistant to be at the bedside to pass things in and out of the body, such as needles or to use a suction device. But these small ports are 8 millimeters. So we're talking about 1/3 of an inch in size for those incisions, right? About the width of somebody's index fingernail. Now, once these ports are placed into the abdomen, we're looking inside with a camera, and then the robot arms that we showed on the last slide actually clip onto these metal parts here. And then the surgeon is in total control of the movement of all of those instruments. So the surgeon will remove the entire prostate, and it's pretty standard for us to take a sample of lymph nodes from the pelvis on both sides. This is to see if prostate cancer has spread outside of the prostate, where in some cases imaging might not suggest enlarged lymph nodes, but there still might be some cancer under the microscope, in which case the treatment would change afterwards. Once all of that is done, the bladder and the urethra are actually stitched back together. And this is a picture here now. You remember from that anatomy slide earlier, there was that walnut in between the bladder and the urethra, but now that is gone. And there's a suture line here, and the bladder was connected directly to the urethra to be able to have the man urinate normally to the outside later on. And this is a balloon of a Foley catheter. It's a rubber tube that's placed, and it's left in place according to the surgeon's preference for about 7 to 14 days. It allows the urine to drain, allowing this new connection to fully heal before we remove that. Some patients may also have a surgical drain in place that usually exits from one of those small port sites that I mentioned before. That's just to divert body fluid away from the new connections that are made and to drain any fluid from the lymph node removal that I mentioned earlier. Typically, that's removed before discharge, usually the next day after surgery. Now, a brief bit about nerve-sparing prostatectomy. This is not for everybody, but it's an individualized decision that can be made according to the surgeon's skills, number one, but also according to the patient's pathology. That Gleason score matters heavily here, and features on the MRI, making sure that the prostate cancer spots are just embedded within the prostate, not bulging against the capsule of the prostate, or possibly exiting that capsule of the prostate and extending outside. In those cases, we don't want to do nerve sparing because we have to get very close to the prostate to spare the nerves. But this is typically a good option in low risk and many intermediate risk folks. And there's many variations we can do. We can do a bilateral, which is both sides, a full nerve sparing. We can do one side, we can do partial on both sides, for example, depending on how the tissue looks and feels essentially at the time of surgery. So a lot of this can be counseled ahead of time, but it really is a game time decision. Our goal is always to remove the cancer and get a negative margin. However, we want to also try to preserve some quality of life factors. So by sparing this tissue immediately next to the prostate, there's less cutting and less cautery, which is electricity or heat used to control. That's going to reduce injury to the nerves, and this can aid in the recovery of erectile function, which erectile dysfunction or difficulty in achieving erection is one of the known issues or risk factors or side effects rather of removing the prostate. And we'll talk about that shortly. So a typical postoperative course, if somebody does go for a robotic prostatectomy, surgery in general takes about 3 to 4 hours. The catheter is left in place to drain the urine, and this is really the man's lifeline for 1 to 2 weeks. You'll receive as needed pain control, and you'll have clear liquids after the surgery, usually until the next morning, at which point the diet can be advanced. We encourage you to get out of bed as early as possible, and this even includes the day of surgery. We want you at least sitting up in a chair or even walking around if it's tolerable for you. And then most commonly, you stay overnight one night in the hospital, and then you'll go home with that catheter in place to take care of yourself at home, keep your pain under control, walk around, and then you'll come back to the office to review the pathology from surgery as well as have the catheter removed. And it's pretty common to be a few days before you pass gas or even have a bowel movement. It's not expected to do either of those before you leave the surgery as long as you're feeling well enough for home. Now, risks of any surgery, sort of the big three that I'll throw up here for any surgical procedure you might undergo in your lifetime: bleeding, infection, and damage to surrounding or nearby structures. So bleeding is very, very minimal. With the minimally invasive approach, the blood loss is pretty low. The need for a blood transfusion is on the order of maybe 1 or 2% of the time, maybe even less at this point. Infection, we give antibiotics to prevent infection. We're also prepping the skin with special solution before we introduce our cuts into the skin and entry of those ports. And then there are structures nearby where we're working to remove the prostate. Portions of the intestines, specifically the rectum, is very close and intimately associated with the prostate. The bladder, the ureters are the natural tubes that connect the kidneys down to the bladder. They enter right next to the prostate. And then blood vessels or nerves, especially in consideration when we're removing the lymph nodes, the blood vessels and nerves that run to and from the legs are in that area. But again, these risks are pretty low. And in general, they are recognized in the moment and any injuries can be repaired. There might be hernias that develop at these small incision sites, but generally a low risk as well. Related to the lymph node removal, there can be some fluid collections in the pelvis. There might also be some swelling of the legs that develops. And then also just a risk of surgery in general. When we're operating within the abdomen, there can be blood clots in the legs or lungs that develop. The side effects of surgery, and these are the two big hitters when we talk about removing the prostate, no matter the approach, even the minimally invasive approach does have these considerations. So urinary incontinence, this is leakage of urine. Once the catheter is removed at that 1 to 2 week mark, there will be leakage of urine in all men. It's essentially a guarantee. And for a period of time, it's going to require pads or use of adult diapers, some kind of system to capture that. We will instruct you on Kegel exercises. These are muscles that men now have to use and think about much more to be able to hold on to and control the urination. We do actually have an excellent program in place that's come about within the last few months. Within the urology department, we have a Center for Incontinence and Pelvic Health. And with our nurse practitioners, we've actually developed a program where the patients will go for a preoperative visit to understand how to take care of the catheter. They'll understand what to expect from the leakage of urine after surgery. They'll learn about different pad and diaper systems. And then after surgery, which is really, really excellent, is a biofeedback, which is essentially small electrodes that go onto the pelvis to help us understand and help you understand what muscles that you need to strengthen and what muscles to best control so you're not overdoing the exercises, underdoing the exercises, and to make sure you're doing them properly for the most optimal recovery. And really the best statistic I can give you, and really the amount of time that it's been studied, is out to 1 year. And especially with the minimally invasive approaches, about 97 to 98% of men have total urinary control by about 1 year. You know, a certain percentage of men will have it at 3 months, a little bit more at 6 months, a little bit more at 9 months. I had a gentleman that we did in October, actually, of 2021. And then by April, actually, he is really just using a pad for security at this point at nighttime because he's a little nervous, but he says the pad is dry. So by 6 months, he's already had total urinary control. And he actually went through the program with biofeedback and everything, and then found it to be very beneficial. The erectile dysfunction, now certainly we're not going to make it better. So if you have poor erections going into surgery, they're going to be poor or even worse coming out. And we do know that it can take up to 3 to 5 years for this to recover, possibly more, but it may be shorter if we're able to do a nerve sparing. And then there are, we call them actually penile rehabilitation programs, which in the beginning is assistance with medications that might just be your traditional Viagra or Cialis. And then there are more sophisticated options that we can offer if things do not recover as expected. But this does lag behind. Even with a perfect nerve sparing with the best surgeon in the world, there's still some stretch and trauma to the nerves that might lead to some issues. And it's going to take some time for all of that to recover and heal. So I just wanted to put one plug in this very end of my presentation, or my portion, for surgery versus radiation, because some of you may be having that question. And that's a pretty hard question to answer because they are both excellent in terms of cancer control, especially if prostate cancer is localized to the prostate. If the spot of cancer is embedded within the prostate, there's a very low chance of it spreading outside, whether you get surgery, whether you get radiation. And with localized prostate cancer, we're at the point of almost 100% 5-year survival, right? At 5 years, if a man undergoes appropriate treatment, almost all men should be living and at least not dying from prostate cancer. They may be dying from something else, but they should not be dying from prostate cancer. Both of these options, or all of these options, have their own individual risks. They have their own individual benefits and side effects. And that's really a shared decision between you and your physician in having these detailed discussions. But also there are some factors that we consider, such as age, what the pathology is. If you have other health conditions and you really are not fit for surgery because you have really significant heart disease or lung disease, then sometimes we might be pushing you towards one option or another. And then preferences regarding side effects and what their impact is on the quality of life is a decision really to be made personally between you and your physician. So I thank everyone, and if you have any questions, we'll discuss them at the very end. And I'll pass it along to Dr. Chen.
So I just wanted to give you a little background on Dr. Chen before he started his portion of the lecture. So Dr. Timothy Chen, he's a skilled physician with 20 years of exemplary service and practice. This is an outside of the box philosophy in the field of radiation oncology, as well as co-investigator for various NCI designated research projects. Dr. Chen is medical director of the Department of Radiation Oncology, specializing in stereotactic radiosurgery at Capitol Health Medical Center, Pennington, New Jersey, from 2012 to present. Dr. Chen is a visiting fellow of the Joint Center for Radiation Oncology in Harvard Medical College and has served 2 terms as chief resident of the Department of Radiation Oncology at New York Presbyterian Hospital, Weill Cornell Medical College. He was attending radiation oncologist, Northwell Health System, North Shore University Hospital, New York, 2001 to 2003. He was the assistant professor, School of Medicine, State University of New York Health Science Center at Stony Brook, New York, 1998 to 2001. And Dr. Chen has served as foundation board member at St. Clair's Foundation, 2011, 2012, and vice chairman, Department of Radiation Oncology at Morristown Medical Center from 2003 to 2008. So thank you, Dr. Chen.
Thank you. Good. Can everybody see my slide?
Yes, I can see it.
Good. Okay, great. All right. So it's wonderful opportunity to share with everybody about this my favorite topic, prostate cancer. Everybody, when they see me, they always ask me, why do you want to be radiation oncologist? And which is, we always sitting in the dungeon and nobody know what we're doing. And we always sit in the basement, and even a lot of medical staff doesn't know much about what we're doing. But when I first started this field, it was Star Trek. If anybody remember back then Star Trek, the doctor, he using this device, I don't know whatever that device was, he saw the wave around in front of the patient, and then he make the diagnosis, and he also treat the patient just with the same, whatever that was. I thought, hey, that could be radiation oncology. So with that, that brought me all this interest in what can we do to improve the cancer care. So for the long term, when we treating cancer, or we see just the cancer and cancer and cancer. But we hurt patients sometimes more just by not pay attention to quality of life. Because sometimes by treatment side effect, you could hurt the patient worse than the cancer itself. So with that, with the prostate cancer treatment, that become the best combination. That means we have a good technology, good knowledge about treating cancer. We also have a good technology, preserve the quality of life. And then best of all, prostate cancer is one of the few cancer sites actually patients get to pick. Just like Dr. Polotti mentioned about, this is the joint decision. It's not like Dr. Chen told me, say, hey, do this. And no, I want every patient come to us. I want them to be happy 10 years later, say, hey, I picked a good decision for myself, and not because Dr. So-and-so asked me to do so. So with that, there's a lot of revolutionizing prostate cancer treatment now, not to mention all of them, just a few things here we've done in the Capitol Health. So here, Dr. Polotti already mentioned about the prostate anatomy that we have seen here. So just to show, this is a neurovascular bundle, and that's where the nerve serving, promoting the erectile function, and that's this nerve, and this is closely touched with it. And yes, that's one of the structures, we need to pay attention to it. And also prostate sitting in that very, very tight area, in the bladder, rectum, and everything all lumped together. Now a daily MRI imaging is so good now, the 3T Tesla, we can see the prostate very, very clearly now. The transition zone, peripheral zone, the capsule, the neurovascular bundle, the bladder, the rectum, and everything. We actually pretty much seeing very good. Now, the technology helps, but technology sometimes does not help. That means we discover more problems. What would that be? Me and my last partner, we scanned 4,000 gentlemen. We found out everybody's prostate actually moving around. It's not that something say, hey, sit still, don't move. No, actually the prostate involuntarily move all the time. And we found out they can move between 2 millimeters to up to 2 centimeters. And then mostly moving anteriorly, that means toward your anterior portion of it. So a lot of them, it could be likely is your rectal movement and then gas. So I call it dancing prostate. So now what? We are treating very, very delicate area. Now you're talking moving around. So can we achieve the problem? Can we resolve the problem, achieve our goal? Let's take a look. Conventional radiation treatment, this one called MRT, IGRT. This is called TrueBeam. This is the newest linear accelerator on the market. So traditionally, we've been using this treating prostate cancer for many, many, many years now. The treatment could range between, in the old time, 9 weeks of radiation. Monday to Friday, every day, 15 minutes for 9 weeks. Now, because the technology is better now, because of we know more about prostate cancer, So this treatment can be narrowed down to about 5 weeks in most of the center. High-dose brachytherapy, that's another one. It's become less so popular, but way back then, the prostate seeds implant, if everybody heard about that, that was a very good treatment. That means we put radiation right inside the prostate instead of radiation coming from outside the prostate. So because the radiation seeds become very nuisance, the patient actually was radioactive. So there's a lot of radiation precaution happening, a lot of unnecessary anxiety. For example, during the 9/11 and after that, I was practicing in New York City, and I got called many times by Port Authority policemen, and they say, Dr. Chen, Mr. Smith is radioactive. Can you explain why? Yes, he had radioactive seeds implant. So nowadays, this has been switched to the catheter now called high-dose brachytherapy, and this treatment requires one night stay in the hospital. Patient need to go to general anesthesia, insert all this catheter into the prostate, and then we assign the radiation through the machine into the prostate. So this is still a very good treatment. It's a one-time deal treatment and then provide a very strong dose radiation to the prostate. So with that, we can do better than that. We mentioned about robotic surgery. Traditionally, a lot of cancer require cut it off. So if you picking your treatment decision for the cancer, if you believe in that, hey, I have a cancer, I need to cut it out. If it doesn't cut out, doesn't count, then surgery likely is your choice. But if you think about if we can find something like no cutting, but with a very pinpoint, very focused radiation, can achieve something very close outcome, is that an option? That's up to you to decide. So that's why I call it steel knife versus CyberKnife. CyberKnife is type of radiation treatment, no cutting. But because of the way the accuracy is so good, the way the outcome is so nice, so we call it CyberKnife. How does that work? This is CyberKnife suite. So patients sitting in this beautiful suite, fully awake, no drugs, nothing. We play music a lot of time. Our CyberKnife treatment suite is very large, have a good skylight. And so we want patient come in as comfortable as possible. And there's no strap, there's no restriction, there's nothing. Patients just lying comfortably in here. Meanwhile, this robot will do all the work. This robot actually packing a lot of high-tech stuff. Start from here. This box, which is a radiation machine, it can come out very sharp beam of radiation machine. And meanwhile, there's a robotic arm. This is mounted on a robot. So this radiation beam can move any direction to the patient, but never touch the patient. Remember, we talk about prostate moves. So there are two cameras constantly watching your prostate. If your prostate moves, this robot will automatically adjust by itself. So this one is one of the biggest inventions in our field for the past 10 years is that real-time adjustment. Because of when we go back to talk about conventional radiation treatment, each treatment takes about 15 minutes. During those 15 minutes treatment, if your prostate moves, we don't know. But with this kind of robotic surgery program, actually we can watch your prostate in every given moment. If it moves, you automatically adjust it, all right? And this table, it have a 6-degree angle of freedoms. It can tilt, it can pitch, it can rotate, met into the criteria we need to the patient position. There's an infrared camera here too, watch patient breathing exercise. So how we achieve all this? Yes, unfortunately, there's something we need to be even more advanced in that. We need to insert a marker into the prostate because of even under the camera here, it cannot see the prostate very well because it's a soft tissue. So we will have to inject some marker. Nowadays, we use the platinum seeds. We use a preloaded needle. Each needle has 2 seeds in there. So 2 needles into the prostate. And yes, we insert it through the perineum, the skin between scrotum and your anus. Capital Health also has introduced this hydrogel now. This even newer technology. That means we insert a little gel, create a little space between your prostate and rectum. So push the rectum away from your prostate. So when radiation treating you, it will have minimized the radiation to the rectum. So with all of this, this is how the hydrogel was inserted. Same thing, you use a needle. And here at Capital Health, we do all at once. We inject the fiducial marker, we inject this hydrogel at the same time, about half hour. Patient does go under sedation. So when they woke up, it's done. So this is what we see on the daily treatment of CyberKnife treatments. So CyberKnife machine will project us, tell us where they see those fiducial marker we talk about, and they provide a radiation dose to the prostate, very, very packed into the prostate. Meanwhile, minimize any radiation to the bladder and rectum. And as you can see, I know you can see clearly, that's the white patch right there. That's the hydrogel did. So pretty much push away radiation dose away from the rectum, so focus more on the prostate. So with this, we very happy with our CyberKnife machine. This is our second machine. And then even be more proud, we are one of the original center in the world participate in this registry trial. This trial have treated 1 million men within those 10 years period of time. Because of those data are so good, United States NCCN guideline has become the first proven treatment since 2017. So it have been used for the frontline radiation treatment now for the prostate cancer treatment because of this effect, because of the side effect profile, because everything it all met into the criteria. So what this CyberKnife, or what we have learned, since we have technology now, we can treat the prostate so precisely. We talk about accuracy of 0.6 millimeters. And then given that prostate did move around, even so, we still achieve the 0.6 millimeter accuracy with 3 hairs line. So with that, what is this technology bringing to us? So historically, like Dr. Polotti had mentioned about, there are 3 groups of prostate cancer patients: low risk, intermediate risk, high risk. So point of view is that we differentiate what group are you, so we can design what kind of treatment is best ideal for you. So we always compare to historical data. So I draw a line here, that means most data compared to at the 5 years. So in the low risk, like Dr. Polotti mentioned, almost everybody cured, 98% plus. Intermediate risk is about 85%. The high risk is about 60% at the 5 years. So this is historical data. What can we do better? That's the thing. All right, we start with the historic data. What can we do next? So for low risk cancer patients, same thing. We provide them with the CyberKnife treatment, 5 treatment. Each treatment is about 45 minutes. Here we do every other day. Usually about a week and a half they are done. The control rate is excellent. So the one has been published by many other centers now. So a lot of CyberKnife centers have been established because of all this wonderful data. Now, what can we do about the different group of people? High-risk group of patients. Remember, those are high-risk group of patients, their control rate only about 60% at the 5 years. So that means a lot of people, the prostate cancer have early recurrence in the prostate. And then if a prostate cancer continue to live, they spread to somewhere else, that eventually that's how kill the gentleman. So back in 2014, this is published data. So that's almost about the time I joined Capital Health. I was very focused on this kind of approach. So they pick out one of the worst group of people, and their PSA is very high, it's 44, and then they are high-risk patient. So they give a combination of radiation. What that means? They get 5 weeks of conventional radiation plus 3 CyberKnife treatment. Found out those historical data of 60%, now it's become about 92%. This is amazing. But obviously, this was a preliminary data. They only pick up a few patients, about 27 patients. So this received a lot of attention, myself too. So with that, I brought this program into Capitol Health. They say, let's do the combination because we have conventional radiation, we have super strong and accurate CyberKnife. Why don't we put them together? So with that combination, ever since that, we collect a lot of data now. So this published in 2016. So again, for comparison purpose, this is historical data, intermediate risk and high risk. By 5 years right here, it's about, we talk about 60% here, but here, actually by 5 years, people reach about 85%. So this is amazing. When we bring this data, bring it higher, so that means more and more people have a disease-free from the prostate cancer. And this curve continue to go after 5 years. So this is another good look about this kind of combination. So with that, our data very much coincide with this published data. This one from 2020, which is we look in more detail now about this high-risk patient combine external beam with CyberKnife or combine external beam with brachytherapy. So we found out those people similarly have very, very nice outcome. So this is between 80 to 90%, historically only about 60 to 65%. Even better, their side effect is minimal. Grade 3, that's how we evaluate patient, how much side effect they get, they usually burning, bleeding, that kind of thing. There's no grade 3 side effect. And most people, about 1 month after the radiation treatment, they go back to the normal baseline. Another paper talk about this kind of combination. This is the most recent study from UCLA and UCSF. They both a very good center. So they did the same thing too. They did this combination for intermediate risk and also a high risk group patient. We found out a few good things, same thing, very good outcome, very minimum side effects. They preserve their sexual function. So this brings us to that the CyberKnife treatment planning, because of the MRI, because of the CAT scan, because of the accuracy, we actually purposely stay away from the neurovascular bundle. So we found out the erectile dysfunction or potency preservation is excellent. So there was a data study about 5 years after CyberKnife, 75% of the people maintain the same potency. The 25% did show some decrease, but most according to the data, those are because of aging. So CyberKnife is another great machine to preserve the erectile function. So here in Capitol Health, we know about options, and that we talk about treating prostate cancer is option. That means you pick under this guideline, you pick what thing is most suitable for your quality of life, most suitable for your daily routine. So for a low-risk cancer patient, you could do a surgery, you could do surveillance, you could do radiation treatment. Those could be CyberKnife treatment, 5 treatment every other day, could be the IMRT. Now we can even pack it down to 15 to 28 treatment every day, or we can do brachytherapy, that's overnight stay in the hospital. Intermediate risk, we can maybe do robotic radical surgery for those selected group of patients, maybe surveillance if you are only Gleason 3+4. Radiation therapy, again, could be CyberKnife only if you Gleason 3+4. But if you are 4+3 or anything higher, so we recommend combine. So the 25 external beam radiation treatment plus 3 CyberKnife, or we can do just a straight external beam. So those could be 25 to 41 treatments, or could be IMRT combined with brachytherapy. So all these are options. Some patients may consider short-term lupron because the prostate gland is too big or a high-risk factor. So we will talk to the patient individually. These are high-risk algorithm. So that means we pretty much do everything to the patient. So we do the IMRT plus CyberKnife, again, 25 plus 3 treatment, or could be IMRT alone is 25 to 41 treatment, or IMRT combined with brachytherapy. but all these patients will recommend long-term Lupron injections. So that's where we are. We're looking forward to have even better outcome, but so far compared to the historical data, especially for the high-risk cancer patient, we're doing much better now compared 10, 20 years ago. But sky is the limit. We continue to improve. So with that, I'd like to bring all of us to a virtual tour. Diane, we have a little virtual tour here for our CyberKnife Center. So this is our beautiful cancer center outside, and we had a little healing garden, and this is the entrance of cancer center. This is the patient's aisle. This is the patient's waiting room area, and this is our treatment area. This is the CyberKnife machine here in Capitol Health, and this is a robotic treatment center, and with this robotic treatment radiation machine. And this is the machine. It's very big. Patient laying comfortable in here. And this is a robot. So it's mounted on a robotic arm. It has 360-degree, about 4,000 different angles available. And this is the attached to this radiation machine. So this little box actually generates very strong radiation, 6 million electron voltage. So the head either automatically can control the size, or this robot can automatically come to this table, pick up the size about the beam. As you can see, the different size of beam. So the robot can automatically come to pick up whatever size it needs, or this called iris. I mean, this automatically adjusts the beam size. So this is the amazing. This is all automatic. This is the table. We ask nobody touch it, because it's precisely laid out. So this is the way when patients come in, they will see the CyberKnife treatment in the resting position. And patient come in, lay down, we make them comfortable, they get to pick the musics. And these are the floor, actually is the imaging receiving these two cameras that projecting through the patient onto the ground, and it will be processing on a computer, so for the doctor and the therapist to see. So these are two high energy X-ray machines. It continuously monitor the patient. If patient move, it will readjust by itself. And this is the infrared camera. When we're treating the other type of cancer, for example, lung cancer, when patient breathe, the tumor move. So this kind of setup will automatically adjust the tumor movement just by the computer itself. We purposely built this center. This room is very big. It's wide open, so patient won't feel claustrophobic. Patient can come in very comfortably laying here. And like I mentioned about, you get to pick your music, preferably no dancing music. And this CyberKnife machine now can treat from head to toe. This is the setup for treating brain cancer. And this kind of setup, and there will be a mask upon the patient's face, because this treatment is so precise. Any little movement, such as breathing, could make you move. So we make this mask on everybody who come in for brain cancer treatment, so that will make them lay more comfortably, reduce the treatment, reduce the movements. And this CyberKnife treatment, which we head cancer, lung cancer, prostate cancer, GI cancer, its application is unlimited now, because we have such accuracy and precision and effective treatment. So this is all based on what patient needs. Again, this is the beautiful skylight. Patient coming here, they don't feel like they are locked in the room. It's very open, it's very bright. And this is the control center. So a physician plus 2 therapists, we constantly monitor the patient movement, the machine movement, the machine report, and then constant adjusting if needed. So even though this robotic machine is so automatic, but it's still human control. So that's our center. And any questions, please feel free to reach us. And this is the number. Thank you, everybody, for participating. Now, I guess we open the podium for question and answer.
So there was a question, could you also discuss the pros and cons of proton beam therapy?
Sure, I can do that. So proton beam, it's another type of radiation machine. It's a super heavy particle, so consider it's a very strong radiation. If you think our radiation like a pistol, proton is like a cannon. So it's very strong. It come in, destroy the cancer cells. So it is good. It's designed for to control a lot of resistant tumor, and also proton had this called rapid character. So that means radiation entrance, they don't exit. So far, according to the American ASTRO, the Radiation Oncology National Community, also for NCCN guideline, and this is still not in the standard guideline for treating prostate cancer. So far, proton cancer is used for treating pediatric cancer and chordoma, the basal scalp tumor. Obviously, it has been used in a lot of major medical centers for research purpose, and also has been used in treating prostate cancer. My personal belief is the following. So the proton treatment is very strong in killing prostate cancer cells. However, it had to be very precisely hitting the target, because of if the proton beam is not just the right place, if it touches the surrounding tissue, that like a bladder, like a rectum, like the urethra, that's equally damaged to those vital structure. So that's why the proton therapy still recommend many weeks of treatment for that reason. Is still in the age of try to precisely treating the prostate cancer scenario. So far, we follow the national guideline. It is still considered not the frontline treatment, but again, anybody interested in the treatment should discuss that in a major medical center who have done a lot of this, and purpose for understand your options.
Okay, the next question is, what happens to prostate with CyberKnife procedure? Is it removed much like with Da Vinci?
Interestingly, after the radiation treatment, after the CyberKnife, prostate still look the same. And that's why I mentioned about prior. Can you accept the fact that after the treatment, prostate is still there? That means cancer is dead, but the prostate still look like as the prostate. Maybe the prostate after 1 year to 2 of the radiation, you slightly shrink a little bit, but it will still look like the prostate. It still feel like a prostate, just the cancer cells inside is dead. That's the reason that after the radiation treatment, the PSA never reached 0, because there's still some normal prostate cells can produce PSA. So answer the question, after radiation treatment, the prostate still looks the same.
Okay. The next question is, what about seeds?
Seeds, right. Seeds, like I mentioned, seeds was first implemented in the United States about 1985. We inject multiple seeds, depends on the size, usually between 80 to 100 seeds. Those could be palladium, could be iodine. That means we literally put a radioactive material inside the prostate. What's good about it? Because this radiation just in the prostate doesn't have to go through your skin, go through anything to reach prostate. So we can pack in very big dose of radiation into the prostate. So the preliminary data, the first 10, 20 years, the seeds looked wonderful. It was very encouraging for a lot of patients going into the radiation treatments. But the problem was the seeds, it is radioactive. Because of radiation decay throughout the time, so patient usually radioactive about 3 months. So we ask patients use all kind of radiation precaution required, such as not too close to a pregnant woman, not to a little kid sit on your lap, and then also concerned about, radiation detector. And also we ask patients, first few intercourse wear a condom because sometimes seeds can come out and wrong person get it. So with that, it has been switched to high dose brachytherapy now. If you are the patient still interested in brachytherapy, nowadays most center does the high dose brachytherapy. So that means no longer radioactive material left in the patient. And those use a remote control seats. Computer remote control send the seeds into the prostate and remove it when it's done. So patient go home. That means after one night stay in the hospital, they go home without any radiation staying there. Similar outcome. I personally have performed probably about 800 seeds implant and brachytherapy. But since the CyberKnife become available, it's much easier for me, much easier for patient because they no longer require anesthesia, no longer require them to go to our operating room or require them to lie in bed for 30 hours because it is same type of radiation. It is same radiation dose that we learn from the seeds implant that we implement into the CyberKnife treatments.
Okay. Next question is, how long does someone stay on the CyberKnife table during a treatment?
45 minutes. 45 minutes. Obviously depends on the size of the prostate. The shortest one we ever done is about 25 minutes. The longest one we have done about 60 minutes. So average about 45 minutes.
Okay. Next is grade 6 in 74-year-old and PSA 0.6. Is active surveillance only PSA and digital exam, or does it include occasional biopsy and imaging?
I could take that one.
Okay.
So in general, from 1 to 2 years from the initial diagnosis, you want to get that confirmatory biopsy, which is a repeat prostate biopsy. And I usually would have folks get an MRI of the prostate 1 year after their diagnosis, whether they've gotten one previously or not, because that may lead us to be able to do the targeted biopsy, where we can hit the suspicious spot with a needle and take samples from there. That's found on the MRI in addition to doing the standard portion of the prostate biopsy.
Okay. Next question for Dr. Chen. Dr. Chen, can you discuss RT for recurrence after RP?
Okay. Over the past few decades, we start seeing people having recurrence because of mostly based on the prior radiation machine was not as mature, and also the prior other type of surgery. So we start seeing two types of recurrence. One is after the radical prostatectomy, and the other one's after the radiation. So the question here is radiation treatment after radical prostatectomy. So obviously we need to make sure it's the real recurrence happen in the prostatic bed in the lower pelvic area. So we have routinely using the one called X-Men scan. That's a PET CT scan. It's X-Men. It's designed to detect any recurrent prostate cancer after the prior treatments. So we routinely perform those scanning, make sure their cancer is not spreading elsewhere. If it did spread elsewhere, the systemic treatment like a total androgen blockade or other treatment is a treatment of choice. For those people, if we identify they mostly recur around the prostatic bag region, we give them radiation treatments. So those radiation treatment usually take about 7 weeks. So we treat a slightly bigger area because we treat the pelvic lymph node and we treat the prostatic bed. And those patients will not be qualified for CyberKnife because we are treating a much bigger area and that's not a focal target for CyberKnife to pinpoint. So we use conventional radiation treatment for those people who have recurrence after radical prostatectomy.
Okay. Next question is, there is a control center with the CyberKnife. Is the physician in the room with the patient, or is he in the control room?
I like to be with my patient as much as I can, but I don't like to share the radiation. So nobody allowed into the radiation room. But all the control center is outside the room. It's a very well shielded. So there will be 2 therapists constantly monitor it, and radiation oncology would be sitting there watching this process. So it is required for a radiation oncologist and 2 therapists there constantly monitor this in every second of the treatments.
Okay. Does prostate function after CyberKnife treatment?
Yes and no. Prostate function, that means that sometime after the radiation treatment, we do have patient experience dry ejaculate. So that means the patient able to achieve the climax, but just with a lesser ejaculate. Most likely is the radiation does cause a little drier on the storage of seminal vesicle, also production of the prostaglandin and prostatic fluids. With that, most of the people do recover after a while, but a lot of some patients still maintain the dry ejaculate. As far as the prostate function, on the other hand, in terms of, I just mentioned, producing PSA, yes, prostate gland still can produce PSA. Those are normal cells that survive the radiation treatment, so they're still producing PSA.
Okay. Next question is, does CyberKnife have same issues of incontinence and erectile dysfunction as does the prostatectomy?
This is the big difference here between CyberKnife and surgery. CyberKnife almost does not produce any incontinence. According to the 1 million men treated for the registry study, only less than 3%. So that means nobody wear diaper, nobody have a urinary incontinence. In the severe situation, for example, people come in already have some urinary incontinence to start with. Obviously, CyberKnife is not going to make it better. But in general speaking, for the all-comer, it's very unlikely consequence, less than 3% if ever. In our center, it's about less than 1% if ever reported. Erectile function, usually we tell people is what you come in with, what you go home with. From those 1 million patient treated registry study, we found out for those people who come in with the erectile function preserved, so usually what they come in with, what they go home with. Overall study showing it's about 75% preservation rate in 5 years. Though that means the doctor see the patient periodically, and I give them a questionnaire, see how satisfied are you on your erection, how confident are you on your erection, and all this. So from those questionnaire, we found out in 5 years, at the end of 5 years, 75% of people still keep the same way. 25% does report a slightly decrease, but from most of the study, from most of the people interpreted this data mostly because of aging. Because of every 5 years, 10 years, the erectile function does decay proportion to the age. I see the next question is HIFU use often and is it good? Dr. Polotti?
Sure. So HIFU is a focal therapy. With surgery or with radiation, we're treating the entire prostate gland. So for HIFU to be effective, you need to have prostate cancer that's in one particular spot of the prostate. And I feel like most high profile centers that do a lot of these, instead of just doing the intense ultrasound waves to a particular spot, they might do what's called hemigland HIFU, which is they treat half of the prostate where the cancer is located. Now, this is sort of a treatment that we're not sure has excellent long-term results yet. There was a study actually from USC where I did my fellowship that said that it did have adequate results for about 2 years, in that the treatment failures were not very tremendous, and it helped people to avoid either primary radiation therapy or surgery for that time period. But a lot of men do go on to need a more radical treatment later on. So it's more of a sort of stepping stone procedure at this point, but still being studied to be a more effective long-term procedure. I'm not sure that, and I would not necessarily go for a whole gland high intensity focused ultrasound. I just think the side effects would be too much.
All right. I guess I'll read. So if you do radiation, can you later do the radical prostatectomy? Dr. Polotti?
You can. So this is known as a salvage prostatectomy, and I think the detail is in the name because you're salvaging sort of a difficult or tough situation. It's required to have prostate cancer again be found on a biopsy. So you do need to have a particular prostate biopsy again demonstrating cancer. And it just makes the tissue, the radiation therapy is great at killing cancer, but it does have effect on the surrounding tissue. The side effects of incontinence are higher, the erectile dysfunction is higher. You cannot do a nerve sparing at that point. It does become very challenging to do a prostatectomy in that setting, but not impossible, but really reserved for select patients.
Good. Let's do one last question. Can you use HIFU to destroy a non-malignant lesion?
Yes, you can. I think it was originally actually approved by the FDA under the purview of destruction of prostate tissue, and just more recently it's received approval for destruction or treatment of prostate cancer. I'm not really sure of a situation that you would be using it to destroy a non-malignant lesion unless you're talking about something outside of the prostate, but